Yeah, ma'am, we are live now. Please start.
Good evening, everyone. Oxy Medical Education Committee and Foxy Medical Education Committee warmly welcome you for this webinar series called AKSHARAM, Episode 7. This is a series which is a brainchild of our president and Oxy, where we bring in teachers from all over the world and all over the country to teach very important topics in obstetrics and gynecology. This topic is about carcinoma cervix, which is actually a preventable disease. A lot of insights is happening into the screening and vaccination, and also in the newer advancements in the treatment modalities. Next slide. I request our president, Dr. Vijaya Madam, to give the welcome address. Vijaya
After
Madam,
the prayer, sir. After the prayer, sir.
We start our program with a small invocation. Lighting of the lamp.
Oxy prayer.
Next slide. Oxy prayer will be rendered by our Dr. Geeta Lakshmi, our Secretary of Oxy. Madam is Associate Professor at Government RSRM Medical College and an eminent teacher.
Thank you, Karpagam, for the nice words. I welcome Dr. Amita ma'am for this wonderful series of Aksharam, and all our participants are eagerly waiting. So we go on with the prayer before we go on to the class. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love.
Thank you, ma'am. Next slide. Sahiti. Now, our president, Vijaya Madam, she is a HOD of ESI Medical College, KK Nagar, and Madam has special interest in high-risk pregnancy, infertility, and laparoscopic surgery, and lot of awards and credits she has achieved, and publications in various national and international journals.
Okay.
Welcome address by Vijaya Madam.
Good evening, all. And this is one of the proud moment every month. I am just waiting for this Friday because I am most interested in sharing the knowledge and making our youngsters to become confident in the basic concepts. So that should never go wrong with them. Recent advances they can always learn in seeing the internet or journals and other things, books. But the basic concept should never forget and should never be never make a mistake when going for the exam. That is where we handpick the experts in each field, and especially we know about the malignancies, lots and lots of change so much. And I was bent upon to somehow call ma'am from Tata Memorial Institute. You all know head of the Institute of Tata Memorial, ma'am is, and she is the correct person to teach you about carcinoma of the cervix. And I will, what is the next? I ask Kiran madam to say a few words, then I'll introduce Amita ma'am.
Kiran Pandey madam,
Yeah,
Kiran madam, the chairperson of Medical Education.
Chairperson Medical Education Committee. Kiran ma'am has been the pillar and the support for us in all our Oxy Medical Education activity. The minute that idea of sharing monthly webinar came to my mind, Kiran ma'am was a major support to me, and she always encourages us. And madam is now going to conduct a big conference in Kanpur about menopause conference. And she's a chairperson Medical Education Committee, FOXY. Over to you, Kiran.
Madam, you're muted, ma'am. Ma'am, please.
Am I audible? Yeah.
Yeah.
Thank you, Vidya, for very kind introduction and words. And it is really my pleasure at such to work with the coordination with Oxy. And Vidya has been always so much keen person for academics. I was just telling Dr. Amita, you will notice she is one person who, I was saying, dives into the ocean, takes out the pearls, I mean, those selected pearls, and then present them to their uses. So you are one of them. Dr. Amita Maheshri, of course, we know all. She's is a professor at Tata Cancer Memorial Hospital. She has been president of the Association of Gynae Oncologists of India, and she's a very, very well-known onco surgeon. And I have been in touch with her because I am also connected with the gynae oncologist. So I know her, the knowledge and her academics about the oncology and her ideas, the vision. They are all of very high standards. And today she will be talking about cervical cancer, which is one of the very common cancers. And even today, I would say, though now we are between, actually, can't say we are in developing countries. Still, in many ways, we are developed. In many ways, we are still developing. So one of those, but still cervical cancer is common. And our women do come into the late stages. So how to prevent it? By early diagnosis, by screening and all that. And early diagnosis definitely gives you a very good edge over the treatment. So all this will be definitely be talked, and our postgraduates will be, I'm sure, very thoroughly will be benefited with the Amita's talk about it. So without wasting any time, let's go ahead with the cervical cancer. And this is one cancer which is, even the WHO is taking so much initiative of 90, and we are all working into that. So it has a lot, so many aspects. Anybody can go on talking about it, but let's hear Amita about how you have
Thank you, Kiran. Lovely words. And I have a pleasure in introducing Dr. Amita Maheshwari, Professor HOD of Gynec Oncology. And you know, she is at Tata Memorial, means it's like a brand. And she's the immediate past president of AGOI and scientific committee member of the International Gynec Cancer Society 2024, member of the Palliative Care Group, co-editor of 4 books: Ovarian Cancer, Cervical Cancer, Endometrial Cancer, and Evidence-Based Guideline for Gynecological Cancer. And this is the last one. Is very, very important, I suppose. And this is, she's the principal editor of India for the official journal ASGO, and 20 books and 125 scientific articles and many research, especially HIPEC. This is the expected question in ovarian cancer, and also the sentinel lymph node biopsy in endometrial cancer. And I think we should take madam's book and read all the PGs, and have delivered many orations and guest lectures. And of course, the area interest will be in what else is there gynec cancer surgery, including surgeries in advanced ovarian cancer. I'm really delighted to hear you, Amita. Over to you.
So thank you so much for kind words. Thank you, Dr. Vijaya, Dr. Pandey, Dr. Sairam, and the entire team and Foxy for giving me this opportunity. Actually, my focus today, I thought it's PG students, and I thought I will focus more on surgical aspect, a little bit about retroperitoneal anatomy, because I presume that prevention and vaccination, it's going to be another webinar. So I would be largely focusing on surgical aspect of cervical cancer management. I think that should be fine. Yeah.
Okay.
Okay. Thank you so much. And I will just share my screen. Yeah. If you want, I can have another some other occasion, but today I have not put because there is so much to talk about management of cancer.
I
That I thought
understand. Yeah, I
I'll focus
understand.
on that with today.
Yeah, thank you for giving us another opportunity to listen to you.
Yeah, I put actually in, pre-invasive, but then presentation became too big. So that's
know.
when I thought I should restrict to one thing and
I
don't want to bother them. So, okay. So let me start with a clinical scenario, and for students to think how will they manage this lady if she comes to them. So 45-year-old Paris, irregular bleeding for 6 months. Pelvic examination showed 3 into 3 centimeter ulceroproliferative growth. Vagina and bilateral para clinically were free. So this was the kind of growth she had. Obviously, a biopsy is indicated, and biopsy suggests squamous cell carcinoma. So just think what is the stage and what will be your investigations and management plan. Meanwhile, I'll take you through some of the important issues pertaining to cervical cancer. And I'll come back to this case a little bit later. So what I plan to discuss, give you an overview on epidemiology, clinical presentation of cervical cancer, the recent FIGO staging, what are the basic principles of management of this disease, what is the standard surgical procedure, and as mentioned about, there are a lot of advances in the field of management. So I will discuss some of the newer advances in the surgical management of cervical cancer, including nerve-sparing radical hysterectomy. What is the current status of sentinel lymph node? Is fertility sparing options in these patients? Role of neoadjuvant chemotherapy to downsize the tumor? And what is the current status of minimal invasive surgery in cervical cancer? So let's start with epidemiology. So globally, if we see, cervical cancer is the 4th most common cancer in women, with over 6 lakhs new cases. And we also know that there is heterogeneity in distribution of cervical cancer, essentially a disease of low resource settings. So if you see, cases are largely in African countries, South Africa and South America and India and developing countries. So there is great heterogeneity in the incidence as well as mortality of cervical cancer across the globe. When we talk about India, it continues to be the 2nd most common cancer, with over 123,000 new cases per year, and 2nd most common cause for cancer-related mortality in women. But what is interesting to note, that cervical cancer incidence over time is coming down in our country. And at the same time, breast cancer is increasing. So until few years back, actually cervical cancer used to be number 1, but now it has come down to number 2. The exact etiology or cause for this is not known, but it may be general process of urbanization and modernization. And we are seeing the similar sort of change in the incidence of cancers in women. If you see lower down, much low, but endometrial cancer and ovarian cancer also on rise in India, but at a slower pace compared to breast cancer. And cervix is coming down, of course, a lot of multiple factors, including overall improvement in hygiene, quality of life, better accessibility to healthcare, as well as screening. Vaccination, I won't say contributed much because that's too new and very, high, very, very low rate of vaccination in the country still. So we know that cervical cancer is caused by persistent infection with high-risk human papilloma virus. And as Dr. Kiran very rightly mentioned, it is the most preventable cancer. A lot is known about the natural history of this disease. We also know that HPV infection is one of the most common sexually transmitted disease. The question is what happens after having infection with HPV. So if we look at the natural history, if we start with 100 women infected with HPV, some 10% will develop some mild abnormality, out of which only 0.8% will become cervical intraepithelial neoplasia or precancerous. And out of that 0.16% will eventually develop cancer if not addressed, if not intervened anytime this. And if you look at the natural history, it is pretty long. So from acquiring to infection to actual cancer, it takes many decades. And that's good thing because we have number of, enough time and opportunities to detect this disease. Now, this understanding of the natural history of cervical cancer is the basis for HPV prophylactic vaccination, as well as screening. And we know that we have various methods for screening. So we have cytology and VIA test, and these tests essentially pick up pre-invasive lesion once it is present. While HPV testing, as you can see from the natural history, it can pick up even before lesions are present. So that's why HPV testing is highly sensitive, but it is less specific because many of these HPV infections, actually body will clear them automatically. So it has a high false positive rate, but it is highly sensitive, and it can pick up lesions to the tune of more than 95% sensitivity of the test. So this is just for the understanding what is the difference between pre-cancer and cancer. So this is as the abnormal cells occupy more and more of epithelium, pathologies would grade from grade 1 to grade 3 or in situ carcinoma. And once there is a breach in the epithelium or basement membrane, it becomes invasive cancer. So this is little basic. Although a substantial proportion, more than 95% of cervical cancers are because of HPV, but important to remember that there is a small percentage of cases which can be HPV independent. And this is more common in adenocarcinoma. And as per recent WHO guidelines, it is mandatory or it is strongly recommended when it's adenocarcinoma of cervix to say whether it is HPV associated or HPV independent. Another point is adenocarcinoma, which are HPV independent, they have a poorer prognosis compared to HPV associated. So this is for pathologists, and the way they do is by P16 IHC, which is a surrogate for HPV infection in the context of cervical cancer. So let's look at risk factors. Who are the individuals at risk of getting this cancer? So anything which increases the risk of acquisition as well as persistent of HPV infection is a risk factor for cervical cancer. That's simple. So what are the risk factors if you look at? So early onset of sexual activity, multiple sexual partners, multiparity, poor nutrition, poor personal hygiene, co-infection with other STDs. So these are some of the risk factors, essentially anything which increases the risk of acquiring HPV infection and its persistence is a risk factor for the development of cervical pre-cancer and cancerous lesion. And another important risk factor is women who has never been screened, and which is so common in our country. So not getting screening is the strongest risk factor. So the next question is, how do these women present? When we look at the median age, of course, it can happen at any age, but the median age is around 5th decade. So if in our own studies, it's around 44, 45 years. That's the maximum number or median age. Women with very early disease may be asymptomatic, and these are the women which can be picked up only by screening. And that's why it's so important to periodically screen women for cervical cancer.
Symptoms, the most common is any form of abnormal vaginal bleeding or discharge. So bleeding could be, say, postcoital, intermenstrual, or postmenopausal. In our setting, especially postmenopausal is quite common because women are never being screened and they may present after the menopause also. Foul-smelling discharge or blood-stained discharge are another common symptoms. Now, if a patient has constitutional symptoms like backache or bladder bowel disturbances, these are often suggestive of advanced stage of disease. So once you on examination, if you suspect it is abnormal looking cervix, the next step is the way it was in our patient, to take a biopsy. If a proper lesion is seen, OPD punch biopsy is the investigation. However, if it is a screen detected patient, when screen test is abnormal, the next step is to do a colposcopy. So colposcope is nothing but a kind of telescope which uses magnification as well as bright light, and we use acetic acid and Lugol's iodine to highlight abnormal lesions. So these are some of colposcopic pictures in individuals who have high-grade lesions. So you can see abnormal vessels. This, this looks grossly, if you see, this is a normal looking cervix, and this aceto-white, dense aceto-white area is suspicious of high-grade intraepithelial lesion. So what we see on colposcopy, we may see abnormal vascular vessels, cuffed crypt openings, punctation, mosaic, again another. So these are like, high-grade squamous intraepithelial lesion where definitely a biopsy is required to rule out early invasive cancer. So once the diagnosis of cancer is confirmed, we need to do further investigation. So routine blood test, including complete blood count, renal function test, liver function test. Renal function test is especially important if it's advanced disease. Patient may have elevated urea and creatinine. A chest radiograph, and some abdominopelvic imaging. The question is which one to do. So it depends upon the resources available. FIGO does not mandate any one particular, but if you have all resources, I think MRI is the best for characterization of local disease. So in early stages, MRI pelvis is the preferred imaging modality. However, if MRI is not available, a CT scan or even a sonography is also acceptable. A routine PET CT is not recommended in early stages, but in advanced stage, PET may be useful because it can tell about the lymph node metastasis and distant metastasis. In previous staging, I think EUA, cystoscopy, proctoscopy as part of staging workup were mandatory. However, the recent FIGO staging system does not mandate the use of these investigations, and these should be done only if clinically indicated, not as a routine. A word about how does this cancer spread. So the three most common modes of spread, and that is generally true for any cancer. One is direct extension to nearby structures, lymphatic spread, and hematogenous spread. So direct extension to vagina downward, to uterine body upward, or parametrial tissue, and bladder and bowel. So these are the structures around the cervix where there can be direct extension. Lymphatic spread, generally it is in a stepwise manner. So obturator or external groups or lymph nodes are commonly first station, followed by higher up like common iliac and para-aortic and extra-abdominal. So in cervical cancer, generally it is a stepwise lymphatic spread. Hematogenous spread, unlike some other cancers, is not so common. It may be seen in certain histologic subtypes, but it's not very common in cervical cancer. The next, I would discuss FIGO staging. The most recent one was published in 2018. And it's also like previous staging. It is essentially based on clinical examination, but unlike previous staging, 2018 staging has incorporated imaging findings and pathological findings in stage assignment, especially in in relation to lymph nodes. So quickly see stage 1, and there are many sub-stages. You don't have to really mark them up completely, but it's good to know these stages because treatment is based on stage of the disease. So stage 1, which is essentially confined to the cervix, further subdivided in 1A and 1B. 1A1, it is 1A is essentially microscopic disease, which is detected on leaf or cone biopsy specimen. So 1A1 is when depth of stromal invasion is up to 3 millimeter. Now horizontal spread, which was part of previous staging, has been removed. It's only depth. And if it is up to 3 millimeter, it is 1A1. 1A2, if depth of invasion is more than 3, but less than 5 millimeter or up to 5 millimeter. 1B1 is anything more than 1A2, but up to 2 centimeter, a maximum dimension of the cervical tumor. 1B2 is more than 2, but up to 4 centimeter in greatest dimension. And 1B3 is confined to cervix, but anything more than 4 centimeters. So this is just to tell you, when I told this patient has 3 by 3 centimeter clinically, so she will, if there is no other spread, will be in 1B2 stage. And here I have just put some, how do we treat these patients and their outcomes. Coming to stage 2, when tumor has spread beyond the cervix, so 2A1 is involvement of upper vagina up to 2/3, but tumor is up to 4 centimeter. 1A2 is vaginal involvement and more than 4 centimeter, upper 2/3 of vagina. 2B is spread laterally to parametrium, but not up to lateral pelvic wall. Stage 3 is either involvement of lower vagina or hydronephrosis or extension to lateral pelvic wall and lymph nodes also. So 3A is a lower vagina is involved, lower third of vagina. 3B is if disease has spread to up to lateral pelvic wall in parametria. 3C is involvement of lymph nodes. And this is something new which was not there in previous staging. So 3C1 is pelvic lymph node metastasis and 3C2 is para-aortic lymph node metastasis. So, this is something either on radiology or on biopsy or on FNAC. And if it is radiologically detected, then we write a small this thing R. If it is pathology, we write P. How this stage was assigned. 4A is bladder or bowel involvement and 4B is distant spread. I'm sure I'm clear on this. Any doubt? I don't know, you can put questions. I think live questioning may not be possible, but if you have any question or any doubt, please put in the chat box. Now let's move on to the next. Once we have determined the stage, the next step is how do we manage? So there are basic principles of management of cervical cancer. So all stages from stage 1 to stage 4A can be treated by a combination of radiation therapy with or without chemotherapy. And radiation is generally a combination of brachytherapy and teletherapy. Brachy is when we give radiation close to the tumor and tele is from outside or external radiation. Now, surgery is possible or recommended only when tumor is very early, disease is very early. So stage 1B2 up to 1B2 or very small 2A1. So these are the tumors where we would do surgery, and that's why it's extremely important to have a proper pre-operative or pre-treatment workup and assign stage properly. Now, even in these cases, both surgery and radiation have same cure rate. So if it's early disease confined to cervix, you can either do surgery or give them radiation. Both have similar outcomes, but there are certain advantages of surgery over radiation. And this I'm not saying just because I'm a surgeon, but these are documented advantages. So one, you get tissue for histopathology and accurate assessment of extent of disease and stage also. So if nodes are positive, it becomes stage 3. It doesn't remain stage 1. If you talk about complications of surgery are often acute and easy to manage, unlike radiation-related complications, which are delayed and very, very difficult to manage. Ovarian preservation is possible in early stages at surgery, and there is better sexual quality of life of patients if treated with surgery. And if recurrence happen, they are easy to manage with radiation therapy. Post-radiation recurrences are difficult to treat. But what is also important to remember that surgery alone may not be sufficient in every patient. What is very important at the end of surgery to have all these pathological parameters mentioned in histopathology report, a detailed histopathology. So there are certain factors, and in cancer we talk about prognostic factors. So there are certain factors, presence of those will make outcome worse. So in case of cervical cancer, it is if there is lymph node metastasis, if disease in parametria, if surgical margins are positive, if there is deep stromal invasion, lymph vascular space positive, or tumor more than 4 centimeters. So these are after radical hysterectomy, you look for at least these parameters, and based on presence or absence, we divide patients into various risk groups. So high risk if node are positive or disease in para or cut margin positive. So these patients, if you do not give any additional treatment, they have very high risk of recurrence, and therefore we give them adjuvant chemo and radiation. So eventually this group of patients will be treated by 3 modalities. You did surgery, then radiation and chemo. And the morbidity of this 3 modality is very high. If you had treated with concurrent chemo radiation, outcomes would have been same. And these are the risks. This is something we want to avoid doing surgery in these kind of patients. Intermediate risk, if it is more than 4 centimeters, if there is deep stromal invasion and lymph vascular space are positive. So mind you, these parameters actually you will get to know finally on histopathology. In these cases, we give additional pelvic radiation to prevent relapse. And patients who do not have any of these risk factors, they are classified as low risk and they are kept under observation. So this is the basic philosophy of management. And the third principle is, as far as possible, either you treat with radical radiation with chemotherapy or radical surgery. And that's why when you have a large tumor where you know that most probably this patient would require additional radiation with or without chemotherapy, we generally do not treat them with surgery, although a big tumor may be technically operable, but we prefer treating them with concurrent chemoradiation because complications of 3 modality treatment is very high, but there is no survival benefit in doing surgery followed by chemoradiation compared to just treating with radiation therapy and chemotherapy. So that's the third and important principle of management of cervical cancer. The next question is what should be the extent of surgery? So how much disease we remove? I said that surgery is advisable only for cases when disease is confined to the cervix, but then also we do remove surrounding tissue. And that is unlike, surgery is done for benign condition where we just remove the uterus. Here we have to remove surrounding tissue, that is parametria as well as vagina. And why this is because any microscopic spread in the surrounding tissue, we want to make sure that margins are adequate and negative. And we also remove lymph nodes because these are common sites for metastasis. So in early stage where surgery is done, up to 10 to 15% patients can have lymph node metastasis. I think it's good to know how we classify radical hysterectomy. This is older classification, Piper classification. Some people still use it, and I think I'll define this one only. So class 1 is extrafacial total hysterectomy. No ureteric mobilization, no vaginal cuff, just cervix and uterus are removed. And this is okay for very, very early stage, like stage 1A1 kind of disease. Class 2 is also known as modified radical hysterectomy, where uterine artery are dissected medial to ureter. Uterosacral ligaments are divided midway. and cardinal ligament also up to half, and part of vagina is removed. This is old up to 1/3 removed. Ureters are not really mobilized much, but pubovesical ligament is not cut here. In class 3 or classical radical hysterectomy, it's little more than class 2, where there is more dissection. We go more lateral and remove more amount of parametrial tissue as well as vagina. Classes 4 and 5 are not really used. So just to tell you, how do we decide what should be the extent of disease? So in stage 1A1, we can just do class 1 hysterectomy, or if fertility preservation is required, trachelectomy or radical cone. In 1A2, class 2 or modified radical hysterectomy with lymphadenectomy, or a radical trachelectomy or radical conization. 1B1, again, here you would do class 3 radical hysterectomy because there is slightly increased risk of microscopic spread. So this is in diagrammatic representation of various classes. And as I said, first 3 classes are also only clinically practiced nowadays. So the amount of para we removed, this is in real life. So this is like when we are very close, it's class 1. Medial uterosacral and medial part of cardinal ligament with upper third of vagina is class 2. And when we go right to the lateral pelvic walls and remove the entire paracervical tissue with more length of vagina is class 3. This is another classification which is more anatomic based, but I think for your this thing, it may not be of interest. Now, as I mentioned, lymphadenectomy is a very important component, and we have to remove lymph node bearing tissue from all sides of blood vessels. So lymphatics run along blood vessels, and they are named after these vessels only, their anatomical location. So I'll give you a little bit overview on pelvic anatomy, retroperitoneal anatomy, a little bit on vascular anatomy and pelvic nerves. So this is quite familiar. So this is known as adnexal triangle between round ligament and infundibulopelvic ligament. I don't know how often you need to go in retroperitoneum when we deal with benign cases, but in malignancy, we always take retroperitoneal approach. So how do we enter the retroperitoneum? We enter in this space between round ligament and infundibulopelvic, incise this peritoneum. And the moment you cut, what you see from lateral to medial side. So here I have put, for orientation, this is on the right side. Lateral to medial, you see psoas muscle, genitofemoral nerve, external iliac vessels, and internal iliac. So further dissection, you will, in this loose areolar tissue, you will be able to identify the ureter, which runs along the posterior sleeve of the broad ligament. So broad ligament is essentially double layered fold of peritoneum, which extend from lateral surface of the uterus all the way to pelvic wall. And it has one anterior leaf and the posterior leaf. So this is the posterior leaf. Anterior is the one which we have cut and to enter the retroperitoneum. You can see ureter, which is attached to posterior leaf of the broad ligament here. Okay, for further dissection, anteriorly will take you to paravesical space. So which is essentially a space between a paravesical, medially it's bladder, anteriorly pubic bone, laterally obturator, and posteriorly cardinal ligament, and base is pelvic diaphragm. So this is just to show you how we access retroperitoneum. By incising, this is the anterior leaf of the broad ligament. From lateral to medial side, this is psoas muscle, external iliac artery, external iliac vein. And, if you understand this anatomy, there is nice loose areolar tissue, avascular planes. And if you remain in avascular plane, then, surgery is really very smooth and hardly any bleeding. So this is how we enter the retroperitoneum. And down there, you will see pelvic floor or levator ani muscle. So that's how we approach in surgery for radical hysterectomy. So this is generally the first step. The other important space which we have to access is pararectal space, and this is, as the name suggests, it is lateral to rectum. Medially, it's ureter, laterally hypogastric or internal iliac artery. Anteriorly, posterior surface of cardinal ligament, and posteriorly, it is sacrum. And base is again by pelvic floor. So this is pararectal space. So by now you can make out these paravesical and pararectal. These two are paired bilateral lateral spaces. And these are separated by cardinal ligament or Mackenrod ligament or transverse cervical ligament, whatever name you want to give it to. And ureter is running here. It runs through the substance actually of cardinal ligament. Uterine artery generally forms the upper border of this ligament. Now, other important spaces when we do cancer surgery is rectovaginal space between the rectum and the vagina. And it is bordered on either side by uterosacral ligaments. So uterosacral, it's again a triangular fan-shaped ligament which runs from posterior, from up our lower cervix and upper vagina all the way to rectum and sacrum. So major fibers actually would end in rectum and some will go to sacrum. And this ligament, it divides this pararectal and paravesical space. And also lateral part of this ligament has autonomic hypogastric nerves. So this is again diagrammatic representation to show you rectovaginal, pararectal and paravesical spaces and various structures separating these spaces. So once you cut these ligaments, uterosacral and cardinal, actually there is no space. It's just one big space. These ligaments, they falsely divide this into various spaces. Another very important space anteriorly is vesico-cervical space and bordered on either side by vesico-uterine ligament. The deeper part of this ligament has autonomic nerve fibers which supply to urinary bladder. Again, very important when we do radical hysterectomy. This is just to show how vesico-cervical space is developed. This is anterior leaf of ureteric tunnel. This is the ligament or tissue between the bladder and upper vagina. And this is vesico-cervical space, and this is vesico-uterine ligament. Pre-sacral space, also known as retrorectal space, is rarely used. It's done when we are doing exenterative surgery, but not for radical hysterectomy. A little bit about vascular anatomy. So it's in upper abdomen. We have renal veins and IVC, which is to right to aorta, and inferior mesenteric artery. So these are some important landmarks. Now, another important landmark is bifurcation of aorta, which happens at the level of L4 vertebra generally. And this also coincides with the position of umbilicus in most individuals. So this is important when you are doing laparoscopy, not to directly go posteriorly. There is a risk of hitting in this area. Common iliac bifurcates at the level of pelvic rim, and you can see ureter crossing from lateral to, this structure is ureter, from lateral to medial side at this level. This is a video again showing retroperitoneal anatomy of upper abdomen. So this blue structure is inferior vena cava. The other one is aorta to the left, and these are lumbar veins. This is union of two common iliac veins. The tubular structure there is ureter. This is right gonadal, which drains in IVC, while on the left side gonadal drains in renal vessel. And these all thin fibers, I don't know if you can appreciate, these are hypogastric sympathetic nerve fibers, so which we have to preserve when we are doing lymphadenectomy in this area. Some important vascular landmark and of, internal iliac, which is the main artery which supplies the pelvis. It has one anterior and posterior division. And what is important, anterior division, various branches, including uterine artery, Posterior division is a very small one. It is generally 2 to 3 centimeter from the bifurcation. And why it is important? So if you are doing internal iliac ligation, as in case of obstetric emergency or any torrential bleed, just do it 3-4 centimeter away from the bifurcation so that we don't take this posterior division, which essentially supply gluteal region. It has parietal supplies, so we don't want to take posterior division. So like it somewhere lower down, 3-4 centimeter from the bifurcation. Another important structure you will see here, obturator nerve, and below obturator nerve in obturator fossa are artery and vein. Now, uterine artery, it crosses the ureter at the level of internal os. So we know water flows under the bridge, and uterine vein is generally below the ureter. So it's uterine artery, ureter, and uterine vein. That's the relation from ventral to dorsal. So pelvic area, just remember it has a very, very rich supply of blood supply and can have a very thin, fine, delicate veins, venous plexus. And it's extremely important when we are in retroperitoneal area doing surgery, not to do blunt dissection, because these vessels are so delicate and get injured very fast. And if we injure, it's very difficult to control. So the best is to use proper sharp dissection, identify vessels, and then ligate them. So some important landmarks, the union of internal and external iliac vein. If injury happens at this level, it's very difficult to control. Another one is union of two common iliac veins, again, and lower end of IVCs. These are some very critical areas one has to be extremely careful not to injure. A word about our friend, philosopher, and guide for any pelvic surgeon is ureter. And because of its location and relation to female reproductive organs, it's very, very prone to injured at various locations, right from infundibulopelvic ligament at crossing of uterine artery and while it's entering in the bladder. So the most common site for ureteric injury is its entry in the urinary bladder, and most injuries are ischemic injuries. So one has to be again very careful when we are doing radical hysterectomy, not to totally denude ureter of its blood supply. Now, how we prevent? So the best way is to identify ureter. It's also not only in oncological surgery, but if you are doing difficult surgery, say in endometriosis or large fibroids or any where pelvic anatomy is distorted, it's best to identify the ureter before we proceed. And how we identify, one way is to look for peristalsis. And if you palpate between fingers, it feels like a snip kind of feeling, or it feel like a cord between fingers. So that's how we identify. So I'll show you a video of radical hysterectomy for the same patient. So as I mentioned, she was 3 by 3 centimeter mass. We did a MRI, which did not show any enlarged lymph nodes. There was clinically no involvement of parametria or vagina, and on MRI also. So she was staged as stage 1B2, FICO 2018, and was planned for radical hysterectomy. Now, incision, it can be a vertical or transverse. Maillards, Journeys, even Phenyl is good in a thin patient. Generally, the first step should be to move or mobilize bladder away from the cervix, especially if it's an anterior lesion, because rarely you may find dense adhesions between cervix and bladder, which will hamper surgery. So next step, we start with lymph node dissection. And it's the same video clipping where I'm showing how to enter the retroperitoneum. And this is the first step for any radical procedure. What we are seeing from lateral to medial side, we are doing on the right side. So what you're seeing here is psoas muscle. Over that runs genitofemoral nerve and external iliac vessels. And this is paravesical space. We have to develop this space so that lymphadenectomy can be proceeded and done successfully. So you can see bifurcation. I don't know if you can appreciate, there are two vessels. So this is external iliac and the other one is internal iliac. This white structure over psoas muscle is genitofemoral nerve. Make sure that we do not injure nerve. I'm using a cautery electrosurgical device. You have to have a good quality of electrosurgical unit. The cautery setting is generally 30 coag and cutting, a bland mode. This is the entire external iliac group of nodes, and if there is tissue between external iliac artery and vein, that is also removed. The next is to go towards obturator fossa. So the metallic instrument is called as vein loop. We retract vessels with that so that vessels are taken away. And white structure down there is obturator nerve. We remove the entire nodal bunch. It's just not picking up some fat globules. You have to remove nodes from all sides of vessels. At this point, you'll be able to see various branches of internal iliac. The next step is to ligate uterine artery. How do we identify uterine? Is generally first branch of internal iliac and it runs medially. We take it at its origin. And there may be some small branches. So take care of every branch. We ligate or clip them properly. Otherwise, it can lead to torrential bleeding as we are dealing with vessels directly. So this is descending branch of uterine, which is ligated. The next step is to separate ureter. As I mentioned, ureter is adherent or attached to the posterior leaf of the round ligament with the mesoureter. So when we want to take uterosacrals and McEnroe ligament, we need to mobilize the ureter from its attachment. This is infundibulopelvic ligament was clamped, cut, and ligated. In a young patient, ovarian preservation can be done, but she was 45-year-old, so we did not preserve her ovary. Now we are cutting the posterior leaf of the broad ligament all the way to uterosacral, and this is pararectal space where you can identify hypogastric nerves. Now, similar steps are done on the other side. We develop spaces, pararectal and paravesical. This is another approach to access obturator fossa. We retract vessels medially. So this is external iliac. Again, uterine artery taken on at its origin and cut and ligated and reflected medially. So whatever lymphatics or, if anything, any malignant cells running in lymphatics, they are taken in the specimen. This is pararectal space. So now is the posterior dissection in rectovaginal space. We have to mobilize rectum so that uterosacral ligaments can be taken. And this is a type C or class 3 radical hysterectomy. Now, when we do this dissection, important point to remember is that fat belongs to rectum. Leave it behind. Don't take it in the specimen, and that only will give. So this is the entire uterosacral ligament. You can see. If you have some energy source like ligashore or harmonic, we can use that. And this is sacrum. So this is a classical radical where we have taken the entire uterosacral ligament. The next step is cardinal ligament or transverse cervical. Again, all the way close to lateral pelvic wall, we'll clamp this ligament and cut and ligate. The last bit is anterior dissection. This is vesico-uterine ligament. We need to mobilize the bladder away. Depending upon the length of vagina you want to remove, you have to mobilize. Unnecessary dissections are not advocated because this will lead to injury to autonomic nerve supply and post-operative ureteric complications, bladder and bowel complications. How much vagina to remove? So 2 centimeter or 2.5 centimeter of vagina is good enough. You don't have to remove upper 2/3 vagina. It's not recommended anymore. And a preoperative colposcopy, whether to do for all cases, generally not recommended, but one can do, especially if vaginal involvement is suspected, so that you can margin can be planned properly. At the end, you suture vaginal wall. We prefer suturing. Some people leave it open, but the problem is we have done lymphadenectomy. A lot of lymph will come through vagina, so I prefer suturing and put a drain. At the end, look for any, proper hemostasis. This is the specimen. You can appreciate the amount of paracervical tissue we have removed. So if, in early stage cervical cancer, outcomes are excellent, more than 85 to 90% survival rates. However, there can be some complications of radical hysterectomy. So intraoperative injuries to various organs we are dealing with, which can lead to bleeding or injury to ureter, bladder, bowel, nerves. So the best way is to have proper exposure, know the anatomy well, and if identified, recognize it early and repair it. Early post-operative complications are generally related to infective causes, including fever, UTI, pelvic abscess, wound infection, or chest infection, atelectasis. Rarely there can be a fistula formation, less than 1%, or pulmonary thromboembolism. We always give a thromboprophylaxis for all patients, as well as antibiotic and other measures to prevent DVT. What is worrisome is late complications in the form of bladder bowel dysfunction and sexual dysfunction and lymphedema. And as I said, these complications are related to injury to autonomic nerves, sympathetic and parasympathetic, which supply these organs. I don't know how much time I have. Should I continue? Do I have time?
Yeah, you have.
Yes, madam, you can continue.
Yeah, you have.
Okay. So this was, a traditional way, but I'll discuss with you in brief what are recent advances. So if you see, cancer surgery has undergone a paradigm shift. As a surgeon, radical, ultra radical surgeries, which when I was undergoing training, that was the norm. Bigger the surgery, better the surgeon, but that's no more true now. What is extremely important nowadays to individualize the surgery, and because it's important to recognize that organ and function preservation is as important as how much you remove. So how much you preserve is equally important as how much you remove. And that's because as we progressed in oncology, we realized that quality of life is extremely important for survivor. We just don't want to give them quality, but we also quantity of life, but we also give them quality of life. So some advances has happened in cervical cancer surgery. I'll briefly touch upon these. So let's start with nerve sparing. As I said, that injury to autonomic nerves, which run in lateral part of uterosacral and deeper part of cardinal or McEnroe ligament. This is one of, major issue with class 3 radical hysterectomy, and it can lead to long-term bladder and bowel dysfunction in the form of either retention or overactive bladder. So in order to preserve these nerves without compromising oncological outcome, the concept of nerve sparing radical hysterectomy has been studied quite extensively, and nowadays we prefer doing nerve sparing radical hysterectomy. So this is just a conventional, when we remove entire ligament, while we know that lateral part of this ligament contains autonomic nerves, hypogastric nerve, or deeper part of uterosacral ligament. So in nerve sparing surgery, we identify these nerves, spare them, and remove rest of the ligament, so that autonomic nerve supply to bladder and bowel is intact. The other important aspect is fertility preservation. Not so relevant still in Indian context, because most our patients actually, they complete fertility by the time they come to us, or they have such big lesions where fertility preservation is not possible. But nonetheless, this is something which we all know. So one way of preserving fertility is to preserve the body of uterus and only remove cervix with surrounding tissue, what is known as radical trachelectomy. So this can be called as radical conservative surgery. A French surgeon, Daniel Darzo, was the one who initially performed these surgeries and propagated. So what we are doing, essentially removing cervix, upper vagina, along with surrounding tissue, but preserving body of the uterus and suturing it with the vagina, along with. So indications for radical trachelectomy, we have to be super selective. Of course, the most important person has to be desirous of fertility. It has to be very early stage disease where risk of spread is very minimal, way beyond cervix. And there should not be any evidence of lymph node metastasis, and biopsy has to be a favorable one. Pre-operative workup is, of course, a proper consent and informing the standard of care and what are the risks involved with fertility preservation. That has to be done properly. You have to be sure that patient is fertile, otherwise, and there are no other infertility related factors. MRI is mandatory because it tells a lot about the location, the size, parametrial extension, and the length of cervix from the tumor, which is important. We want to have some margin, can't cut on the body of the uterus. So roots can be vaginal, which was initially, but nowadays people prefer abdominal root. We are more comfortable doing procedures abdominally. We really have lost the art of performing good vaginal surgery. So abdominal could be open, laparoscopy, or robotic. The first step is to do lymph node dissection. Either send lymph node for frozen section examination. If positive, you cannot do conservative surgery, then patient has to be treated with definitive treatment. And generally, we abandon the surgery and treat them with radiation therapy. Or nodes are negative, then we can proceed with conservative treatment. Or some people prefer doing two-stage procedure. If frozen facility is not available, then do only lymphadenectomy first and plan for second stage procedure when nodes are negative. These are some of the steps of radical vaginal trachelectomy. Essentially, what you have to develop a cuff of vagina and reflect the bladder. Vaginal cuff is sewed over the cervix and clamps are placed to give little traction. Then we need to mobilize and identify and take paracervical tissue. So it's not just simple removal of cervix, but we also need to remove surrounding paracervical tissue, that is medial part of Macenrods and uterocervical ligament. We need to mobilize the bladder properly, and paravesical space is entered, and ureter is palpated in bladder pillar. So it is little more than what we do in just a simple vaginal surgery. And at the end, I think it's recommended to place a cerclage suture so that to prevent cervical incompetence. We also send a specimen for frozen examination because make sure that margin is negative, at least a centimeter negative margin is required. And that's why a specimen is sent for frozen examination. There are some of the images showing how to do open abdominal surgery. So the same steps, essentially you're preserving body of the uterus, just below the isthmus we cut and suture it with the vagina and remove cervix along with surrounding paracervical tissue. And at the end, suture uterus to the vagina without cerclage suture. So complications are, intraoperative could be injuries, but post-operative complications. So what is, I think, is of interest that cerclage may get expelled and amenorrhea may be associated with cervical stenosis. So one has to be careful not to, make sure the cervix doesn't get stenosed and can put Foley's for a few days. Now, it's important to do post-treatment surveillance. So this is general surveillance, actually, 3 monthly for first 2 years, 6 monthly up to 5 years, and annually lifelong. And every time we do clinical examination, history, pap smear after radical trachelectomy, endometrial cells can present. So cytologists should be aware, and a colposcopy and ECC and MRI every 6 monthly or annually later on. We tell patient not to conceive for at least 6 months, preferably a year. And if they conceive, management has to be in a high-risk obstetric clinic. So overall pregnancy rates are reported to the tune of 40 to 80%. Infertility may be a little more because of cervical factors, and there could be surgical adhesion formation and infection. First trimester abortion rate is almost same as in reported in general population, but there is increased risk of second trimester miscarriages, essentially because of loss of cervical factor and a lack of mucus plug. There is increased risk of ascending infections. Preterm deliveries may be seen in up to 30% and term delivery in 40%. Now, delivery is preferred by elective cesarean section and using low vertical or classical incision. Overall, if well-selected patient, risk of recurrence is less than 5%, which is quite acceptable in these patients. The other complication of conventional management is related to lymph node dissection. There is a risk of intraoperative injury. We know while doing lymphadenectomy, I showed you the video where we are around various important structures and any one of them can be injured, and that can be post-operative morbidity also. And especially in obese patient, and if patient needs radiation for any indication, then this can be a very, very difficult situation to deal with. So what is the, and we also know that risk of metastasis in early stage cases where we do surgery actually is less than 20%. So a substantial proportion of patients actually undergo unnecessary extensive lymph node dissection. So how to manage these cases, or how to know lymph node status with least morbidity? The way is to do sentinel lymph node biopsy. So sentinel lymph node is essentially the first draining node from any organ. So this is not only to cervix, but actually any organ, and more commonly this sentinel node is used in breast cancer. We do use in endometrial cancer and many other penile cancers. So these are some of the cancers where sentinel nodes are extensively used. Now, how we pick up these nodes? We use either blue dye or radiocolloid, or a combination of two. And more recently, we started using indocyanine green, which requires near infrared fluorescence imaging. So where do we inject dye? So we can inject either at these two locations or 4 locations, or peritumorally superficial. So this is again a small video showing a combination of blue dye and radiocolloid for sentinel lymph node mapping in a case of cervical. So these are radiocolloid filled syringes. These are provided by nuclear medicine colleagues. They have to be given prior to surgery. It could be 3 hours or 12 hours, depending upon the size of radiocolloid used. We use small size colloid, so we generally give after 2 to 3 hours is good. In this patient, it was given at 4 locations superficially, or you can give peritumorally also. After this is not done under anesthesia. It's done without anesthesia. Patient is shifted to nuclear medicine department. This is lymphoscintigram. You can see this is the primary tumor and both sides lymph nodes are seen. Now, after induction, we use blue dye and it's injected at same 4 places, 0.5 ml each. And after that, blue dye takes nearly 15 to 20 minutes to reach. So we inject it prior to opening the abdomen. After that, but after anesthesia, retroperitoneal spaces are opened, and you identify, be very careful not to disturb these lymphatic channels. So you can see this blue channel. So this is the lymphatic channel, which will be, you can see this blue node. So this channel draining to this blue node, and this is sentinel node. So the first node which is draining from the cervix. Okay, so this is blue node. Just to know whether this the same node was picked up on radiocolloid, we have this handheld gamma probe. We put it on the node, and you can see at the monitor the activity. Okay, so this 4,000, 5,000 is primary tumor, 500, etc. is lymph node. And once you remove the node, make sure that that's the correct node you have removed, and again check for no residual activity remaining. We also have this ICG. This is indocyanine green. As I said, it needs infrared camera. we have this inbuilt with robotic system, but it's available for open as well as laparoscopy. So this is Firefly mode in robotic platform. We identify, this is a robotic video actually. So identify the lymphatic channel and the node where it drains. So this is the green node. It looks beautiful. And this is the sentinel node here. Okay. So before making sentinel node as standard of care, one has to do a complete lymphadenectomy, make sure that your sensitivity is above 95%, then only start doing sentinel lymph node. The other and very interesting concept is, can we downsize the tumor by giving chemotherapy so that we can operate or do surgery in patients who were advanced stage? And we did a study, a randomized trial comparing this concept of neoadjuvant chemotherapy. Unfortunately, our study and there is another randomized study, both failed to show that giving neoadjuvant chemotherapy to downsize the tumor, do surgery, is superior to doing chemo radiation. So what our study showed, that patients who received chemo radiation, and as I said, that's the standard of care in advanced cases, they actually have better survival than doing chemotherapy and surgery. So currently, neoadjuvant chemotherapy, it is not recommended to make patients suitable for surgery. If patient is advanced stage disease, it's best to treat them with chemo and radiation therapy. Now, how about the role of minimally invasive surgery? I'm sure you all will be excited to know, can laparoscopy or robotic be used? The answer is unfortunately no. So there was a very large randomized trial which showed that patients who undergo laparoscopy or robotic surgery, their survivals are inferior to those who had open surgery. So currently, open surgery is the standard of care, and it is not recommended to do minimally invasive surgery in patients with cervical cancer. Although in endometrial cancer, minimally invasive is preferred, but in cervix, it is recommended not to use. What about radiation therapy? As I said, anything more than stage 1B2 generally would go for radiation therapy. So radiation therapy plays important role in the management of cervical cancer. One, as a definitive treatment in post-operative settings and at relapse. So in definitive treatment, we give combination of radiation along with chemotherapy. And as I mentioned, radiation is done by external beam as well as brachytherapy. And concurrent chemotherapy is actually cisplatin, 40 milligram weekly given along with external beam radiation. And EBRT, we give 25 sittings, 25 fractions, 2 gray each. The overall treatment time for radiation therapy should be less than 55 days. That's important because otherwise prognosis is adversely affected. Radiation can also be used in early stages by, there we generally do not give chemotherapy. It's only EBRT and brachytherapy. And if it's a very early disease, microscopic kind of disease, radical brachytherapy alone is okay. So these are the patients ideally for surgery, but if they are not willing or they are not fit to undergo surgery, they can still be treated by radiation therapy. Post-operative adjuvant, I mentioned, when do we give post-operative radiation therapy with or without chemotherapy? And at relapse, we can treat with radiation therapy. Or if there is metastatic disease, bone mets, brain mets, we can do palliative radiation therapy. These are colorful diagrams you will see radiation oncologists make. They like to document tumor size, site, everything in great details, and beautiful diagrams they draw. Just for postgraduate students, I think it's important to know what is point A and B in relation to radiation therapy. So these are two anatomical points used in radiation therapy of cervical cancer. So point A is 2 centimeter above the external cervical os and 2 centimeter lateral to endocervical canal, and this generally coincides with the position of uterine artery and crossing the ureter. The dose at point A is important to reduce morbidity, and point B is you can say 3 centimeter lateral to point A. So it is same 2 centimeter above and 5 centimeter lateral to midline. And this is the position of obturator lymph node. So it's important that patients get adequate doses of radiation therapy. These are some of brachytherapy applicators which are being used by our radiation oncologist. The last bit about cervical cancer in pregnancy. So in our country, this is the most common cancer, maybe breast and cervix, the most common cancer we see in pregnant women. This is just a flow diagram to say to show how we manage. So if women is diagnosed with this invasive cervical cancer, if it is early pregnancy and not desirous of continuing the pregnancy, if it is operable disease, we would do radical hysterectomy with fetus in situ. So this was the case where it was early pregnancy, patient was not keen, multiparous, and we did with fetus in situ radical hysterectomy. If it is advanced stage disease where surgery is not possible in early gestation, combination, we start with external beam and chemotherapy. And if spontaneous abortion happens, good. Otherwise, we do hysterectomy and then give brachytherapy. Or many times we may just terminate the pregnancy first and then go for treatment, because at times it is messy once we start EBRT to do anything. If it is beyond the age of viability, we may consider, if patient wants to continue pregnancy, we can give neoadjuvant chemotherapy, paclitaxel and carboplatin. Follow carefully till fetal maturity and then do cesarean section. If it is early stage disease, again, one can do radical hysterectomy at the time of cesarean section. But if it is advanced after cesarean section and patient recovers, we treat them with concurrent chemoradiation. So this is general, very simple flow diagram of management of cervical cancer in pregnancy. One question, I don't know what is the current practice. Do we always screen women for cervical cancer antenatally? I don't think in India we do, but that may be something, looking at their cervix carefully is a good idea when they come during antenatal checkups, at least at the time of first visit. So I think with this, I'll end, and this is my last slide. So in oncology, it's the disease biology which is the king. Appropriate selection of cases is the next most important thing. And then technical maneuvers are of lesser importance. So that's very important as an oncologist. When you grow and develop, you realize that you need to understand disease biology. You have to select a case suitable for kind of treatment very, very carefully. So if I do say radical hysterectomy for stage 2 disease, I'm not really going to do a good job, because that's not appropriate treatment for that particular stage. And as we learn that minimal invasive surgery is not good in cervical cancer, so we have to accept and understand what is appropriate for the patient. So at the end, the whole concept nowadays in oncology is it's not one size fits all. You have to individualize the treatment, and at the end, it's a teamwork. So you need to have a radiation oncologist, a medical oncologist, a surgical pathologist, because I mentioned a whole lot of, oncology is based what pathologists tell us, and of course, a gynec oncologist. And if you are wondering why gynec oncologist is looking like this, after, working long hours, we are no more those beautiful, delicate gynecologists. We become like this. So thank you very much for your attention. Thanks. And I think, sorry, I did not, put videos on. You suggested me to have some, but I really don't have those videos on LEAP and cryo. I do have in my presentation, but I think anyway, it's already 7:34, so it can be for another day.
Thank you so much. And it was such a wonderful and mesmerizing videos and your talk, and just it flows like that, like Kaveri we say in Tamil Nadu, how the river flows like that, and it speaks how an oncologist differs from gynecologist. That really shows the your Tata
Huge
Memorial
respect,
branding is there. Yeah, the branding always goes a highway, and I'm sure that students are really benefited. I have only one question. Nowadays, the point A and point B are still there, Amita?
No, not there. But for students, I mentioned because examiners may still ask. So
Yeah. Okay.
radiologists don't use point A, point B. In fact, nowadays, radiation also like surgery has many advancements. Cobalt is rarely used. Nowadays, they use more recent technologies.
CCMs, yeah.
Yeah.
Okay.
So let me just say, I have huge respect for obstetricians and gynecologists. I think I could not cope up. That's why I opted for oncology. It's easier to be an oncologist than to be an obstetrician. So yeah, hats off to you guys. So
Thank you so
Thank you
much.
so much, ma'am.
yeah, thank you.
We would like to call you for our annual conference. Hope you are not busy at that time in April. It is in March,
Right,
our
ma'am.
annual conference. I would definitely should come and give us a talk to our Chennai people, Oxy Chennai, one of the biggest society of Oxy it is.
Madam, thank you so much, ma'am. It was very informative. And I always believe these oncologists are basically anatomists who know the pelvic anatomy or any anatomy so thoroughly. All the spaces, everything is so thoroughly learned. And the way you people dissect is really a treat to watch, madam. Definitely. And your last two slides were absolutely amazing. Those, the biology is the king and, selection is the queen. That is so true. And how we are trying to overcome these biological aspects with our, princesses manipulating things. Thank you so much. It was a really
Right.
amazing discussion.
Thank you, madam. We would like to have a pre-invasive lesion. So that session we would like to have with you, ma'am.
Today, I think we may not have. I do have few, but I think it will be cutting, short if I.
We'll
I
have
don't
another
have.
session, madam.
We'll have another session, madam, with you.
Yeah, I think it makes sense to have another session on pre-invasive because that itself will take, an hours because I have couple of videos and the whole concept of pre-invasive cancer and how to manage it.
Thank you, madam. It was an excellent presentation. Thank you so much.
Thank you so much,
Thanks.
madam. And
Thank you, ma'am.
I mean, as you say, I think we all should start focusing on, screening pregnant women as well, so that we don't miss out these early lesions. And
Are you doing, Dr. Amita?
No, we don't see pregnant women,
Oh,
so
not all. Okay, yeah.
So we have actually started doing HPV vaccination for all pre-pregnant when they come for preconceptual counseling, and all these girls, before the age of 15 we give 2 doses, and after 15 we give 3 doses. We have started doing that for fertility patients. We suggest them to get it done, and then. But
WHO has revised little bit, and in fact they recommend you can give single dose up to 15, even up to 20. They are saying that you can give single dose.
Up to
And
20?
we are doing a study with CERVIX because CERVIX, we have not done any study with single dose currently. So for Gardasil and CERVIX is not available. Gardasil and Gardasil 9, you can give single dose up to 15 or maybe up to 20, actually, what WHO says.
Oh.
CERVIX, we are doing studies looking at their immunogenicity of single dose. So yeah, I think single dose may be the way forward.
Even in Australia, they have started actually giving single dose for a lot of people. They have even.
It has become standard of care in Australia because their incidence is very low and they are, so.
Only one question, Dr. Amita. This follow-up of the case of cancer cervix, should we do both colposcopy and pap smear, or is it, because in your slide.
Right. So that was only in the context of fertility preservation. If you have done radical trachelectomy, then it is recommended to do colposcopy every 6 monthly.
And pap smear too?
MRI, pap smear too. But pap smear, actually, this is little older. Nowadays, it has changed to HPV based screening. So in India is still somewhat heterogeneous. So that's why I kept cytology. But routine follow-up after radical hysterectomy actually is a symptoms, a good clinical examination. And cytology, it's not always, recommended. We cannot, it's not required to do cytology, especially if patient has been treated with radiation. Pap smear is not recommended because many times false positive may come because of radiation related changes in the cervix, in the epithelium. So we don't do cytology on follow-up of patient who is treated with either radical hysterectomy or radiation.
So only colposcopy.
No, not even colposcopy, a good clinical examination and symptoms.
Okay, that is enough. Okay,
That is the only, thing.
Okay.
It's recommended.
Even in normal smears, we see a lot of reactive ATPs. So,
Right.
So there are even normal pap smear cytologies, we see quite a lot of reactive ATPs.
Have you done away with pap smear?
So not completely. We are actually, we have a separate preventive oncology wing. So we are doing HPV as well as most women undergo VIA and HPV, but some we would do cytology as well.
Okay.
So we have not
doing. Villi.
We prefer VIA. Villi can be done along with VIA, but VIA, acetic acid is more important. We do use after acetic acid Lugol's iodine also.
Okay, also.
But primarily it is acetic acid.
Okay, HPV and
and HPV and VIA.
Okay.
That is the way we are doing. But we have very good cytology department.
Okay.
So our, the main concern with pap smear is these false negative and false positive. So in our experience, the sensitivity is around 70%, which is pretty good. So we can continue with cytology, but the general recommendation is to go away with cytology-based screening program, even VIA-based. That's what WHO is suggesting now, to move towards HPV only. So, but I think considering India is a very heterogeneous resources and accessibility, we can't just say HPV everywhere. So we have to have, more options to our population. And that's why.
Do you do liquid pap, Mita?
No, we don't do liquid. We do cytology conventional. So there was a study was done by our cytopathologists, and they found that there is no benefit of liquid LLBC over conventional. And we continue to do conventional. In fact, I told you we are having a conference. So we have actually, so from TMC Calcutta, and she's a pathologist. So we can ask using the discussion.
Yeah.
Are you using barging in? No problem. So
we were just discussing about conventional pap versus liquid pap. What is Tata Memorial's take on that?
So Mumbai, we do conventional cytology because we compared, and our pathologists are happy with conventional cytology. They don't see added advantage of doing liquid base. But madam is from TMC Calcutta. It's not part of Tata Memorial.
Okay.
She's a faculty for our conference, and she just happened to be in this room. So I thought I'll ask her also.
Ma'am, we're using liquid-based cytology. We are using thin prep. But our primary screening is by the HPV testing.
Right.
On the vial. Yes.
Okay.
So sorry for interrupting. I came to take my back.
We are nearly closing. No problem.
We are routinely doing via, madam. So are you doing in your center?
Yeah, they are doing.
You are asking me? We are. So see, we have, one is Tata Memorial Hospital. We do have many outreach programs. Okay. So in our many of these outreach rural programs, we still have VIA as the primary test. But at Tata, actually, we do HPV based screening. So VIA, we are doing in rural areas where access is limited. VIA is the is the test performed by our.
Why is it you are not doing liquid pap? Anyway, you are doing HPV, right? So you can as well do the cytology in that liquid.
So reflex we are not using. So we are collecting anyway. So advantage of liquid is if you are doing reflex cytology. we are collecting HPV, we are collecting cytology separately. But yes, the main concern is cost of liquid cytology.
Okay.
We actually bargained with the company, but it is still more expensive compared to our conventional smears.
I know.
And our pathologists are quite happy with conventional smears. They are
Okay.
happy. They don't see much issues with conventional smears. So. But we did a study, compared conventional and liquid, and results were same. So the cost is the main reason why we don't see any added advantage and increased costs.
But the sample from conventional, will it be enough for HPV testing also, ma'am?
No, that is collected swab. Yeah,
Swab.
we use a separate swab, for
Swab.
HPV.
Because they say the liquid-based cytology, that reagent, something is very expensive, they say.
That is it.
Yeah,
They take
that's the
only
problem.
swab.
Yeah.
So liquid base, yes, that's the problem. Cost is the concern. Whether you use
yeah.
prep or PET, cost is a main concern there. It's nearly 3 times the cost of our conventional smears.
Correct, ma'am.
For us, VIA is a part of screening for NCD, ma'am.
Like same
In
for
our
us.
So that is why it has been made mandatory in our government institutions where we do the VIA as a part of NCD.
Okay. So yes, this is based on, in fact, VIA-based screening based on a study done by Tata Memorial Hospital. It was done in, of course, there are other studies as well, based on which it is recommended. But I think we do it, as I said, it depends on the population we are dealing with. In our hospitals, we prefer HPV or cytology. In rural setting, we do VIA-based program screening. So
Thank you, madam.
Thank you.
Okay.
Thank you so much.
Okay, thank you.
Now I'd like to pronounce the vote of thanks. I thank our President, Dr. Vijaya ma'am, our Secretary Geeta Lakshmi madam, our Chief Guest, Dr. Kiran Pandey, for this excellent opportunity for us to learn from the experts all over the country. And our special thanks to Amita madam for, in spite of her conference in going on Tata Memorial, she could spare time for us. And this is an excellent session, and we really enjoyed the videos, the beautiful delineation of the anatomy. That is what really amazes whenever we see a oncologist performing surgery, and we learn anatomy, keep learning and relearning anatomy again and again. Thank you so much, madam, for this excellent session. And I thank Shield, who has been a part of this for this academic sessions every time. Thank you, Sahiti and Chitrakala, for this platform, and all the delegates who logged in. And really, I think, please tell your friends to join every time, because every time we really have one pearl from the ocean, as Kiran madam said. Vijaya madam is picking up the pearls, and we are actually seeing the pearls share their knowledge through every webinar of AKSHARAM. Thank you so much. Wish you all a very happy Diwali and a very happy weekend. Thank you so much, and good luck, madam Amita ma'am, for an excellent conference. Wish you all the very best.
Thank you, Amita. Good night. Happy Diwali.
Thank you, ma'am.
Thank you.